Make sure you grab a phone. Good, good. Or anything we could. I'm sure Dr. Introduce her. For all their help. About, I don't know, 10 or 12 years ago, Hassan Naki and a few other people here started something called the Metro Detroit Sleep Society. We met on a relatively frequent basis, and I think over the years, Robin and Sleep Solutions have probably sponsored about 25 meetings like this. But they're good quality, and I just want to thank them for all their support over the years, for sleep technicians, for sleep physicians, pulmonary physicians, everything they do. They do a good job. I think they'll take great care of your patients. I don't think there's anybody better. And we're especially pleased tonight to have Dr. Teofilo Lee-Chiong come from, he's a professor of medicine at the University of Colorado. And you've read his books, you've seen his articles. He was going to be Speaker of the House, but actually, Paul Ryan, to that you're stuck with us.
I was informed that gathered tonight in this room are among the finest professionals in the state of Michigan. I have to say I'm both honored and humbled. But we also know deep down that we are not enough, right? That there's not enough of us to do the things we need to do for people with chronic respiratory failure who need non-invasive ventilation. So there are three solutions to that. One is to have every one of you work twice as hard, which will kill you. Train twice as many people, which will kill the system. Okay. Or and efficiency. And I'll try to, in the talk today, talk about science and go into some technology. I'm making two assumptions tonight. One is that you do not know anything, and because of that, I'm going to go through a very basic science here. And my second assumption is that you are not stupid. So I'm going to go deep also into technology. So this is my talk is very generic. I'll go through all the modes of ventilation. Modes are to a patient that you. So I think it's your one best suits to the patient. To understand what failure is, and through the stages of talk about different types of non-invasive ventilation. So let's start know that breathing changes during sleep. The sleep state creates certain changes in ventilatory drive, ventilation, respiratory response to hypercapnia and hypoxia. Therefore, as a rule, we could expect that in a sleeping person compared to wakefulness, the CO2 will rise a little bit and the oxygen levels will drop a little bit. The response to hypoxia also is altered by the sleep state. Here you will see saturation levels, ventilation, the most pronounced, of course, wakefulness, dropping during non-REM sleep and reaching lowest levels in REM sleep. The same pattern occurs for hypercapnia. In addition, you will see that the active threshold for hypercapnia changes throughout wake, non-REM, and REM. So hypoventilation or respiratory failure starts really when you have episodic nocturnal hypercapnia. Now let me explain to you what it is. So you have somebody who has imagined having a fixed metabolic rate, but they have a regular airflow interrupted by either apnea or hypopnea. And they recover with a hypercapnic, so with the hyperventilatory overshoot. So you will see that during periods of hypopnea, and more so with apnea, that you will have carbon dioxide loading, and you will see unloading during this phase of hyperventilatory post-apneic event phase. Therefore, the longer the apneic episode, meaning the longer this phase becomes, the higher will your CO2 reach. In addition, the shorter the post-event hyperventilatory phase, the higher your CO2 will become. So again, CO2 will rise the longer this becomes prominent and the shorter this is seen. So that's the first phase. The second phase occurs when you have inadequate compensation. So you have periods of apnea and hypopnea, but rather than normalizing your CO2 levels, they remain abnormal because you are unable to unload CO2 effectively. And there are many reasons for that. Okay? Altered lung mechanics, VQ abnormalities, leptin resistance. Okay? Let me show you this example of a rat model you've seen before. This is a mutated rat model with no leptin. And like you know, leptin and ghrelin really control appetite, food intake, and weight. And to remember the mnemonic well for leptin and ghrelin, think of leptin, L, being produced by adipocytes, lipid cells, L. They make you lose weight, L, because you eat less, L, becoming leaner in the process. On the other hand, ghrelin is your factor that makes you gain weight, G. They're produced in the gastric cells, G. It makes you gorge, and therefore by gorging, you become ginormous, G. And then leptin resistance is also important because in persons who have leptin resistance from obesity, you also have hypercapnia from a blunted respiratory drive. And finally, the continuous nocturnal hyperventilation extends, it controls your increase of the awake CO2 normal level. If you were to highest levels, both factors are at the same time. So here you have continuous and continuous. So therefore, in your patients, you may in the daytime that are very different from what they need at night. So let's start with a case. 70-year-old male snoring with hypersomnia, lifelong smoker, therefore has severe advanced COPD. Also obese with obesity hyperventilation syndrome. Because of the weight, has chronic back pain and therefore high dose opioids. And because of the problem also taking high dose sedatives. This patient will come with a set of problems to look like this. They may have oximetry that looks like this. This could be COPD, non-REM COPD, representing sleep wakes, lateral supine lateral. Could be REM, could be diaphragm paralysis. But this patient how do you address this? Which one do you think takes first? My bias is that you have to treat, you cannot ventilate. And without ventilating, you cannot correct the hypoxia. So if you're going to go through this, you can treat the airway obstruction with either CPAP or EPAP. EPAP of a BiPAP, for example. For hyperventilation, you can increase the pressure support, provide a rate, or give volume. And for hypoxia, you can either increase the EPAP, increasing FRC, pressure support, increase tidal volume, provide the volume, or increase the rate. So you will see here that you can control 4 things. You can control EPAP, CPAP, pressure support, rate, and volume. So therefore, all ventilators, okay, can be characterized into 2. A pressure support that delivers a prescribed pressure, and a volume control that delivers a prescribed tidal volume. It's very simple. Let's go first with pressure control. The first generation pressure control machine is very familiar to everyone here. It's your usual BiPAP, where your CPAP, pressure support, and rate are all manually entered. So for example, this is a simple BiPAP reading. You have your EPAP here. You wanted to put a pressure support of, let's say, 4, so therefore you put an IPAP of 8, and you put a rate. Everything is manual. And for chronic hyperventilation or respiratory failure, the ASM has advised that you adjust the IPAP and EPAP levels to maintain upper airway pages. For example, if the upper airway is closed and requires, let's say you start with 10/5, and you needed an EPAP level of 10 to open up the airway, then you increase both, changing the 10/5 to 15/10. If, after opening up the upper airway, you remain a patient with hyperventilation, that's when you increase your pressure support. So this is what they recommend. So first of all, let me go through this first. So this is the typical bi-level pattern you will see. You will see a lower EPAP level here, a higher IPAP. These things you should also, the triggers, the start inspiration. There's a mechanism, cycles, inspiration, also an inspiratory time that you keep. And everything, once you understand, we'll go through this one. For breath, a assistance whenever the patient breathes on his or her own. If I am in a spontaneous mode and I'm only breathing at 8 per minute, then the machine will only provide 8 breaths of a BiPAP. An ST, a spontaneous rate is set, let's say, at 15, breathe at 8, then the machine will include additional 7 breaths, okay, mandatory to that. A mandatory breath is quite simply set at 15 breaths per minute. And there's a sigh. A sigh is an augmented breath, usually about 150% more than your usual breath, that's given about once every 100 breaths. This will open up the lungs. The trigger that starts the cycle from exhalation to inhalation, okay, can be many things. It could be automatic. Okay. There are systems that can detect the total circuit flow, can look at the leak from the system, okay, subtract the leak from the total circuit flow, and create the patient flow. Using that flow parameters, you can then determine the best trigger. There's also a volume trigger. Most of us are familiar with that in the ICU, where you have a change in the volume, in this case, perhaps 6 ml. If that is generated, the machine will trigger in the inhalation. And there's a shape. Okay? There's a shape pattern that can be patient's breath, or certain boundaries in that shape. It would either trigger in an inhalation or cycle off into an exhalation. Cycle, therefore, can shape from inhalation to exhalation. You can also cycle off there. There's also a maximum IPAP that can redundant cycle in many machines. There are different ways of triggering the breath in, and there are different ways of triggering the inhalation in non-invasive machines. Right time flow pattern, and I'll show you, able to provide you with two prescriptions. One that can be more useful for daytime use, and one that's needed for nighttime use. And we'll talk about VAPS AE2 as the adaptability feature. And finally, safety. In the ICU, in the hospital, you may not need too many alarms, but patients at home, you need power for disconnection feature. This is a BiPAP. You have a lower EPAP and higher IPAP. Patient breathes in and goes out. Instead of being a square pattern, you will see that there is a pressure release starting at the end of the start of the end of exhalation and releasing further so that the patient will breathe more comfortably. Again, this is a comfort feature. You may or may not need it for your patient, but try it. This is a ramp. Many people, the pressure in the setting over time. This time, you can control that. You can control the delivery of the rise time from a very fast delivery to a very slow delivery. And you can either go to 1, 2, 3, 4, 5, or 6 rise times. And like I said, you have to try on the patient and see which one is more comfortable for them. There are different flow patterns. Okay. Here you have a square flow pattern wherein the airflow is constant. You may also see a ramp where airflow is completely first through. All of these are comfort features. I cannot tell you whether the square or the ramp or the C-flex are more comfortable. If the patient likes it, then you have the answer. If they don't like it, there are many things you can do to play with to make it more comfortable. So this is your typical first generation BiPAP. For example, you may set it initially at 8/4, or this could be anything. This could be 20/5, 25/10. But in this case, 8/4, you give a pressure support of 4. And then according to the manual published by the ASM, every 5 to 10 minutes, if you have a low tidal volume, hypoxia or hypercapnia, you then increase the pressure support. Every 5 to 10 minutes, increase. So from here, 8/4, 10/4, 12/4. You also change the mode, okay, from spontaneous time mode to a time mode. Second generation is what we now call volume assured pressure support. The CPAP, EPAP is still manual, the rate is still manual, but then you have a way to automatically adjust for pressure support. And the way to do that is to have a targeted tidal volume. So what happens now is that the VAPs will provide you with a fixed EPAP to open up the upper airway. But it will give you a variable IPAP, which will go up or go down depending on the target tidal volume. For example, if you look at this second generation setting, you will have EPAP of 4, similar to the first example. You will have an IPAP of 8, but instead of being fixed at 8, this will vary from 8/20 to 25, giving a pressure support that ranges from 4 to 21, depending on your target tidal volume. What's the target tidal volume? You can use a formula, 8 ml per kg, 6 to 8 ml per kg. Ideal body weight. Remember, somebody who is overweight, 600 pounds, doesn't have a lung that is this big because his lung is small. You can also bring the patient in early, which is what we do. We bring the patient in, start perhaps at 6 to 8 ml per kg, and ask the patient, is this comfortable for you? If they say, I'm still struggling to breathe, then increase the pressure support. On the other hand, if they say, yeah, it's too much, I feel too much pressure, then try lowering the pressure support. Also ask your physician. The patient may have had a pneumonectomy, or diaphragm paralysis, or recurrent pneumothorax that will demand specific changes in the setting. So here you have, again, like I said, a fixed EPAP, let's say 4. Then you have an IPAP that varies from 4 to 25, depending on your target tidal volume. If the target tidal volume is reached, IPAP will not change. If the target volume falls down, for example, they are in REM sleep, right, the IPAP would increase to try to increase again the tidal volume. You will also increase it throughout the night, maintaining your tidal volume. So instead of having a fixed pressure support, that pressure support is constantly changing. During the night, during the day as well, whenever you see upper airway closure, if the machine does not have an automatic EPAP, you have to increase it. Okay? You have to increase the EPAP. By the same time, when you increase the EPAP, also increase the IPAP to maintain pressure support. If you see hyperventilation during the night, you can either increase the pressure support, trying to reach a bigger tidal volume, or you may increase the rate. Like most of us know here, we should probably prefer this to this because you may have an increased rate but a small tidal volume. You may think you have a good ventilation, but that's just dead space dead space rather than alveolar ventilation. And if hypoxia persists, you can increase the EPAP again, increase pressure support, or simply add oxygen. Now this is very important. If somebody is hypoxic, they may hyperventilate. Okay? So to develop synchrony between the machine and the patient may be very difficult in somebody who's severely hypoxic. Third generation. This is your volume assured pressure support AE, where everything now is automated. So here you have superimposed on the earlier slide where you have the tidal volume go here and your pressure support that changes. Imagine now that you can also measure upper airway resistance, and that you now also have an automatic EPAP, your regular EPAP, included in the machine. So therefore, it not only adjusts for tidal volume, it can also compensate for upper airway resistance by changing the EPAP. So now you have a variable EPAP, control for upper air obstruction. You have a variable IPAP to achieve your tidal volume goal, and you have a backup rate. So the machine will set an ideal backup rate. Some machines will take the first 50 breaths. Okay, they will pick, so let's say you have 14, 16, 14, 15, 15, 15. They put a median there of what your baseline rate will be. Once that's fixed for the patient during the night, the rest of the evening, if the patient has a respiratory rate higher than the baseline level, the machine will not kick in the breath. However, if the respiratory rate should drop below that, let's say in this case, then the backup rate will kick in. So it's important that the backup rate will not kick in if the patient is breathing out. So it's all synchronized to the cycle of inhalation and exhalation. If you look at the BAPS device and just compare it to CPAP, BiPAP ST, and BiPAP ST BAPS, volume assured pressure support. And this is a simple study on 10 subjects with obesity hyperventilation. You will see that the CO2 levels, as measured transcutaneously, is lowest with the BiPAP ST BAPS compared to CPAP and BiPAP ST. So here you are. This is your pressure control modes. CPAP, everybody knows what CPAP is. to one continuous pressure. BiPAP, pressure control, and pressure control SIMV. And I'll go through that very quickly. I know all of you know this. BiPAP S mode, like I said earlier, you have an inspiratory and an expiratory pressure, IPAP and EPAP. The machine will allow the patient to breathe spontaneously. So these are all spontaneous breaths. So therefore you see that the duration varies from breath to breath. But every time the patient initiates a breath, the machine will provide the necessary BiPAP setting. BiPAP spontaneous time. This is set, so this is your spontaneous breath. Spontaneous breath. If after 6 seconds, because the rate here is set at 10, if after 6 seconds there's no breath, the machine will kick in a mandatory breath. You will also see that the inspiratory time differs between spontaneous and mandatory. For the time mode, it's delivered by the machine. The machine cannot adapt to the patient. You will see that inspiratory time every 6 seconds, because it's set at a rate of 10, the machine will put in the breath. Time mode, spontaneous. 6 seconds after there was no here, the inspiratory time changes to breath. It's almost identical. Similar. It's fixed. This is identical to ST mode except for level 1 exception. PC SIMV mode. Pressure control SIMV is very different. Let me spend some time with this. So depending on the rate you put in this case 5 breaths per minute, the machine will start a cycle of time. In this case, 12 seconds. Every 12 seconds, the machine will look at the patient. The patient has not breathed at all in that 12 seconds. It will put in a mandatory breath. If the patient has breathed during that time period, the machine will either give a spontaneous breathing breath or an assisted breath. Now let me explain to you what those mean. When I say breath, the machine provides the breath. Pressure support and EP. So for example, second time period or during the next patient a in this case patient was breathing before this time period, so the patient received an assisted breath. So it differs between whether the patient breathes or not. Again, you'll go through this when we talk about SIMV mode. But the more important thing to consider here is that this is pressure control. So the breath you get here, okay, is not a volume control breath, it's a pressure control breath. So we have difference between pressure control and volume control. Let me summarize. Pressure control, you provide with each breath a prescribed pressure. In volume control, you provide with each breath a prescribed time of volume. We all know what controlled ventilation means. Every time you set up, let's say, you set up 10 breaths per minute, which means that every 6 seconds, the machine will provide the breath for the patient. But in contrast to your BiPAP time mode, which provides you with a pressure support IPAP and an EPAP, this will provide you a total volume followed by a PEEP. So think of this as your BiPAP time mode. Instead of providing pressure support, providing the time mode. Assist control is identical to your BiPAP spontaneous time mode. You have assisted breaths as well as spontaneous breaths. But instead of providing pressure support for your BiPAP, you now provide a tidal volume and the peak. And finally, you have SINV, similar to your pressure control SINV. In fact, the picture looks identical. Instead of giving you a pressure support, it provides you a tidal volume. And we'll summarize this in a later slide. So why is it important? Let's ask a few questions. Does NIV have any benefit? First, let's look at mortality compared to patient with acute COPD exacerbation. Mortality was compared to those with invasive mechanical intubation. So lower mortality in the another shorter length of stay and lower risk for hospital-acquired pneumonia. It makes sense. You like NIV and COPD from patient and initially treated with NIV. Meaning that there are more and more physicians choosing NIV over INV for COPD patients in the hospital. This is initial NIV again, another study from 2001 to 2011, a 10-year period in the US. You will see that the initial NIV increased by 15% and initial INV declined by 3%. Again, it's a trend in most hospitals in acute setting of using more and more NIV compared to INV. You will see this trend most in this. This was 2006, 7, 8, and 9. You'll see NIV increasing from 2.3, 2.9, 3.3, 3.5. It was increased every year. In fact, the hospitals who use NIV the most in this study show the best scores. It is the hospitals with the lowest NIV compared to those with the highest NIV. So hospitals who use a lot and use little of NIV, you will see that all of the measures here, hospital cost, length of stay, mortality, all favor hospitals that use more NIV. Where should it be started? In the ICU, in medical ward? In this study, looked at medical ward use for NIV. Mortality rates were actually dependent on pH balance. So those who are very, very acidotic have a higher mortality rate than those with less severe acidosis. In one survey, this is patients in the worldwide survey in the wards, shows that 2/3 of respondents describe using NIV in the general ward. So we always thought, and when I was growing up and in residency, we always put patients in the ICU and put them on NIV. But 2/3 of respondents globally now report that they're using it in the medical ward. Supervised, but in the medical ward. What about compared to oxygen? So this is NIV plus oxygen therapy alone. You will see that overall admission to the hospital decreased when used both and increased when used only oxygen therapy. The same trend could be seen with this study. this is before home NIV and during home NIV. You will see in a very small study, but the number of hospital admissions decline, the number of ICU days decline, the number of ICU visits also saw a trend in a decline. Finally, I'm going to show you one study. It's called the Barnes study, or the stiff coupling paper. This was a study that looked at retrospectively a program that included a lot of things. Included the use of NIV, AVAPS, AE, pharmacy reconciliation, long-term oxygen therapy, and frequent follow-ups at home for the patient. In the year before intervention, it was 100% readmission rate of patients who were admitted on 2 or more times. When this program was initiated, in the following year, this 100% dropped to 2.2%. What about survival? This is the Conline paper showing that mortality in 1 year in the NIV group versus control group in patients with hypercapnic COPD, that the survival was better. The survival also was better. Not survival, but the parameters were also better. People with hyposcoliosis and cardiac respiratory failure. So, to summarize, we have 2 modes, a pressure control mode and a volume control mode. The simplest is CPAP. Okay? CPAP provides one simple pressure throughout the night. You inhale, you exhale, it's one single pressure. Here, the BiPAP mode provides 2 pressure, spontaneous time, and time mode. Very similar to the BiPAP ST mode, which is a pressure control mode. The only difference, like I said, the only major difference is that the spontaneous settings here have a different inspiratory time, while here the inspiratory time is similar for mandatory and spontaneous breath. You could also consider that the BiPAP T mode is very similar to the control mode. In one case, this provides a pressure, in the other case provides a volume. You can also argue that the BiPAP ST is somewhat similar to assist control, but assist control provides volume, while this provides a pressure. And finally, you have the pressure control SINV versus SINV. The difference again is that this provides pressure, this provides both volume for mandatory and assisted breaths, and pressure support for spontaneous breaths. So here are the modes that you will see for most NIV machines. What are the challenges? Well, we're still talking about hypoventilation, therefore we have to have a way to measure CO2. In the hospital, it's very easy. In the sleep laboratory, less so. At home, very difficult. So when do we need it, and how do we time CO2 testing? We still don't know. And what level of hypoventilation, respiratory failure, hypercapnia do we need to intervene? And how quickly do we expect a response? And as the patient gets worse each day, worse each month, worse each year, how do we appropriately address the varying needs of the patient and how to adjust the ventilator accordingly? If you go through this carefully, you will see there's so many modes here, and that everybody in this room should be able to use all of them. If you have a very stable patient, mild COPD, with a good follow-up, you have a good team to do the follow-ups, then you can get by with a lot of these things. On the other hand, if you're a patient who is severe, very unstable, you're not sure how to follow up the patient over a distance, your team is overwhelmed and they really do not have time or resources to do follow-ups as needed, then use technology. Use the AVAPS technology to make sure that they get the appropriate kind of volume they need over time. Make sure that you have the other devices in place that can address patient accordingly. So the choice of which device to use and which mode to use is very patient specific, very practice specific. The other features are really patient specific. You have to try them on and see what is most common. It is really about the patient. Everything we know about technology today is being designed to help the patient live independently, to be able to empower them to adjust the machines accordingly, if not automatically, then by themselves, and also enable us to extend our reach to beyond the clinic. And hopefully, when we look at our computers, we not only see our patients next to us, but also see them other. Thank you.
Yeah, one comment. I think even in the lab which are joint commission approved, we are somewhat underutilizing the CO2 monitoring and some are not treating the obesity hypertension as we should. We're also probably overlooking the bicarbonate
Yes, true.
in the electrolytes. Can you comment on somebody who's morbidly obese and he is not doing well on BiPAP T mode or ST mode? What point in time do you maybe play that?
Okay, so let me address your question two ways. This really talking about patient obesity, hypertension. First, you try to question what are the clues we have that can identify them. We think today that they are underdiagnosed. There are two clues. You mentioned one of them. It's a high bile fat, okay, and that's very useful. The threshold that most people use is 27. If you have somebody with 27 or more, then you have to consider hypoventilation. The other one is severity of hypoxia. In somebody with simple OSA, obstructive sleep apnea, you should not expect O2 levels to drop to the 80s. If you have somebody with sleep apnea in your clinic, in your office, they drop their oxygen level at night to the low 80s or high 70s, then you have to suspect OHS.
Unless there is a combination of COPD and
Of course.
obstructive sleep apnea. Then
Yes. So it's not simple sleep apnea though. Something else is happening. Something else is causing hypoventilation in addition to upper obstruction. The question is, when do you increase, okay, or how do you go up the ladder from BiPAP to or volumetric pressure support AE? I usually give my patients time to adjust. The time is not longer. I usually give them maybe 2 to 3 weeks to adjust to the machine. If they don't respond at all, if I maximize therapy, patients using the device well, they're compliant, but the symptoms, prominent, there's no change in blood gases, I quickly move them forward.
question I have is, your patient can generally do very well at the time of discharge on BiPAP, but he doesn't qualify for the criteria of the BiPAP as established. Any ways to kind of tweak it around? I think you give it an index of because they're not meeting.
Yeah.
So that subject is, I think, the next discussion here that we're going to have is how do we get from here to the patients who need this in the ways the insurance will allow. And so we'll hopefully answer that. If we don't answer it during this next portion, we can talk a little bit more afterwards.
Talk about the further ventilation.
So servo is very different. First of all, servo is faster. So this changes very slowly. The change is so slow and fast that we want it that way, so that the patient doesn't feel the difference between a change in respiratory flow or volume. With servo, ASV is very fast. Okay? So when you have periodic breathing, and they have hyperventilation and hyperventilation, the machine senses those, okay, and quickly addresses the hyperventilation with a lower pressure quickly addresses the high flow with increased. We hope that over time that the exaggerated
use the adaptable now. All the studies that the drug has used to when do you use? Is there any indication for you?
Okay, so all of you are aware of the survey chat. If you go through of positive error therapy for heart failure, there have been good and bad news. Right? We all heard about the CANPAP, and those of you who don't know what we're talking about it. We also know about the Michael Art's post-hoc analysis that explains a lot of things. We are expecting more from the resident researchers about the survey. The problem with the New England Journal of Medicine is that they have very strict space and requirements for publication. So many things companies provide more clarity. There are questions that thing is it has to address and break down harm. If, for example, so the survey, it's a 7-year-long study looking at over 1,000 heart failure patients who are symptomatic. They're New York Heart Class 3 or 4, low ejection fraction of less than 45%, and they have predominant symptomatic. So when you say symptomatic, they're symptomatic from heart failure, not from the symptomatic. So it's very different. If you have somebody symptomatic from central apnea, they will have insomnia, hypersomnia, disturbed sleep. They didn't look at that. When they say symptoms, they mean symptomatic from the heart failure standpoint. We divide them to control group and put them into ASV group and found out that, first of all, there was no benefit. The endpoint of was reached. There was no benefit except for it decreased age of the lung. Everything else. But in addition, there was a harm. There was both a overall mortality risk as well as cardiovascular risk. We need to understand who these subsets are. The earlier indication is that the EF is 45 and below, but there was some speculation that it may even be lower than 30%. There's also some concern that when they look at intent to treat analysis, that it was probably applied to the study benefit, but also into the harm, and that's quite contentious. So there are many things coming out, and I'm pretty sure we'll get to that. Another study, the ADVENT-HF, is ongoing right now. That is the Doug Bradley group. Again, looking at heart failure, both obstructive and central apnea, and the use of ASV. And we expect that paper to come out probably in about 3 years. Any other question?
We're going to NIV, cough assist, AVAPS, and what's your other product? Specialist?
Trilogy, AVAPS, cough assist, and BiPAP ST.
Okay.
That's it. Hi, everybody. Thanks for having me. I just wanted to take a few minutes. We won't take long on this, but we're going to take a few minutes to talk about non-invasive ventilation, and we're going to talk a little bit about AVAPS AE specifically. And then I'm going to let Joe talk a little bit about, we're going to talk about the criteria for coverage for our NIV patients and what we need to do to get those appropriate patients on the appropriate equipment and make sure that they get covered by insurance. So a couple of quick things first. COPD is the third leading cause of death in the United States. We know that it affects about 24 million people, and only about 12 million are actually even diagnosed. So it's still an underdiagnosed disease. And all of us in this room, as healthcare providers that take care of patients with lung disease, have always obviously been concerned about the care of our COPD patients and what treatments we were providing to them and trying to provide the optimal therapy for those COPD patients, and particularly as they are discharged to home. But recently, because of the Affordable Care Act, COPD is now been added to the list of chronic diseases that are subject to readmission penalties. So for a lot of us, that means a lot of other people are now concerned about what we're doing for our COPD patients. Our hospital administrators, our financial administrative teams are now saying, what are you doing for these COPD patients to reduce these readmissions? They are subject to about a 3%, up to a 3% penalty if these patients are readmitted. I'm sure you guys are all aware of that. But and we know that our COPD patients, actually about 1 in 4, different studies come up with different numbers, but about 15% of our COPD patients are readmitted within 30 days. The cost of that is about $49 million. So it's a very expensive disease, expensive admission that we need to take at some different alternatives and what new solutions can we provide for our COPD patients to keep them out of the hospital. So we're going to talk a little about who can benefit from non-invasive ventilation. And as I'm talking about this, I'm kind of gearing it towards also what we're looking for in criteria for coverage for our patients. So our chronic respiratory failure patients, secondary to COPD. So our stage 3, stage 4, maybe even some of our stage 2. I think sometimes it's important to identify those patients before they get to that severe stage. Those patients that have chronic hypercapnia, those patients that we could probably all think of a couple of those patients as we sit here that we just can't keep out of the hospital, or they're visiting us in our office every other month, and we're doing a round of steroids. We've already provided oxygen. We've tried other therapies, and those patients that we just haven't been able to meet their respiratory needs, and they're still having some respiratory failure and respiratory insufficiency. Those are the folks that we are considering and would benefit from non-invasive ventilation. Our neuromuscular disease patients, our ALS folks, our muscular dystrophies, our MS, our thoracic restrictive disease patients, our kyphoscoliosis, our chest wall deformities, OHS with chronic hypercapnia. Now, OHS is a little bit trickier when you're going to make sure that this patient's qualified, and Joe, I think we'll talk about that a little bit too. Because history has shown that OHS has been effectively treated with a BiPAP ST or an AVAPS unit. So what we're looking for with our OHS patients is still a respiratory failure, some component of where we're showing that they're still suffering from respiratory insufficiency due to OHS. Patients that fail their RAD device. If you have a patient and have a RAD device. It's like BiPAP or CPAP device. So if you have a straight OSA, that's a device for those patients. If they have failed that device, / chronic respiratory failure background, consider non-invasive ventilation insufficiency. They need a different RAD device. They need a different patient interface. But if you have, we have tried on or a BiPAP, maybe they've been on a BiPAP ST, is not enough pressure support, or that is not, doesn't the components that we have in a ventilator, those patients all about the documentation and the history of this patient supporting the need for ventilation. And the reason this is such a confusing, as I visit some of you in this room even, one of the first questions is qualify a patient. What is the criteria? And that there are coverage determined. What I quoted here is ventilator versus PAP devices, the severity, and that is distinguished from ventilation in patient for interruption, or failure of respiratory support leads to death. So what you're doing is your diagnosis that this patient would suffer if we don't non-invasive. And as I said, every becomes a little bit for people. I think I'm going to let Joe talk more about respiratory.
So I think, like I said, a big part of this program is trying to figure out how to actually get these to your patients, get them treated properly. They need the sleep study, or OSA, whatever this is, and they just didn't get treated. And so NIV came out that we could start. This is what they say. And so Medicare, I guess the best way to put it is, they're putting us in a predicament. Go ahead and do it, but we're going to come after you. You don't have it. We're going to pull over. Very expensive piece of equipment. It is gap billing for us, so it's not something months on the insurance. I'm going as long as they're alive. And what happens with that is a lot of companies out there will take advantage of that. And so here to make sure piece of equipment for the patient. You guys can trust enough that we're not going to. There are some other companies, and they're going to ruin it for the patient. And so, in your packets here, if you guys put together pamphlet stapled together here, the different pieces of equipment on there. The second page of that is our criteria for the company for sleep solutions. Now we've met with some different people. There's an auditing company we've sent our charts to that people that have worked for Medicare have been with, and they have actually audited our charts for us to look and see what are we missing, what's Medicare going to look at. And we need to be able to prove that their disease state is such that it requires this piece of equipment. So I don't really want to see a patient. If you guys have a patient that needs a bypass, let's give them a bypass. Let's do what we need to do to give them a bypass. I don't want to push that through. And just because it's difficult, or they don't want to do a sleep study, I don't want them to get this.
And Joe, if you look at Medicare is going to say, what is the least costly piece of equipment that I can put this patient on? And then in your head, if you say BiPAP ST, even if they don't qualify, that's what Medicare is going to say. It's be strict, and everybody, or not everybody, but people will say, well, you know what, I'm going to bypass that. I'm going to qualify him for an NIV. Because there are no qualifications for an NIV. There are qualifications for non-invasive ventilation from our company. Because we is going to come in and Medicare say, well, why didn't the doctor put him on an ST? Would have been okay on an ST. Patient won't qualify for an ST, so I'm going to order non-invasive ventilation. And Joe and I are like, really? Now Medicare is going to look at that and go, really? You're going to give them? I mean, you give you a cost comparison. From a business point of view, a BiPAP ST costs me about $2,000. This non-invasive piece of ventilation here, so when Medicare pays on a monthly basis, $1,200 a month for us to be pretty darn sick. There's point of view in order for them to continue.
You got a hospitalized patient. Hospitalized recurrent exacerbation.
Well,
We
that's
can't
what,
even get them by.
Well, that's where, if you can, I mean, honestly, I'd be.
yeah, Dr. Mackey, if you have a case where you have history showing this patient's been admitted and admitted and admitted, what they're looking for is
History.
a history.
Right.
So we want to say, 2 years ago, a patient presented with COPD, early stage. 6 months go by, now you're building a nebulizer. Another 6 months go by, you ordered oxygen. But what you're doing is you're charting the progression of this particular disease. That's what Medicare is looking for. They don't want to, all of a sudden, yesterday, patient ends up in the ER, and it's chronic hypercapnic respiratory failure due to COPD. And I go, where's this history?
Patients. When we talk to our social workers, we document.
Yeah.
Sorry to you just mentioned there are 12 million undiagnosed.
Right.
So 12 million may show up in the ER with hypercapnic respiratory failure.
I guess the hard part is, and from our perspective, you wouldn't believe how many of these we've seen. So we get a patient, hypercapnic respiratory failure, they're ordering been maybe default. So from an insurance perspective, we got to play devil's advocate and say, well, how do you know?
And my respiratory cap, and I have to put on my audio. All they're worried about is, did you follow this? Did you follow this? Did you follow this? You charted, it's chronic respiratory failure, but there's no record to prove chronic respiratory.
That's not sufficient. You need to have half hour, you have 5 minutes of desaturation. You have to get stage 4. That is stage 1 or 2. Otherwise, everybody will be on one of these antibodies. So those are medicated status for a long time. If you present PCO2, it has to be within 24 hours of discharge. That is stability. Big percent. With bronchodilatation, that's probably why. Thousands of for the same reason that they're not using the inhaler. What's the penalty? Is it going to be up or lower?
I don't think that it's going to matter. I don't think it's going to change either way. It's based
A
on the whole.
readmission is a readmission, right?
But here's what we do
But
though.
when you admit somebody, that's costing just $200 versus somebody costing thousands of dollars using non-invasive cost-effective ventilation, well, I really don't know if it doesn't matter.
They don't specify though. It doesn't.
Okay.
The insurance is 1 to 3% depending on how the hospital did in that area. So if you've got your COPD population at whatever hospital you guys may work for, they're going to look at that as a whole and they're going to say, all right, your readmission rate is this. Here's your penalty. It's 1 to 3% of your billing for that
So
diagnosis.
regardless if you're using a home
No,
run or
no. If they're in an ACO, I don't think any of you guys are part of an ACO. That's a little bit different because now that's your savings based on that. But based on the information that Dr. Lee was talking about, with the amount of these patients that are being readmitted and the cost of that, if you're in an ACO and it's costing, that it's costing $10 million right now to service those patients, and that's because of those admitted, one admit's going to pay for that NIV unit. And the other part of this program is we have a respiratory therapist, who's over there. She's
a little
She's
shy.
out
She
visiting
doesn't
these
want to
patients
talk.
every month in the home, staying on them, making sure that they're coming in for follow-up visits, making sure that they're using their medications appropriately, using spacers as needed, re-educate. If they're not using these units, we pick them up. So if they're a non-compliant
We are
patient,
going to call you and we are going to say, you know what, Mrs. Smith, everything we have tried, she is not using it. Now you can smack her hand because you know she's going to end up in the ER. She's going to end up back on the floor and you're going to be doing rounds on her again. But we're trying everything that we can, which any home care company should be doing. The whole goal here is to keep them from going back into the hospital because we know the financial hit on the hospitals, it's going to be huge. Whether you're feeling the impact or not, most of the hospitals have now developed some type of program where there is a group of people that are going around and they're saying, doctor, this patient's been here again, what are you going to do about it? We want to step in as a continuum of care. We want to take care of those patients. Yes. Kim, would you mind coming up here, please? I'm going to put her on the hot spot.
No, what is non-compliance? What's
do we-
considered non-compliance?
Yeah, what is
When you have a patient that you know is not using it because you have an SD card inside the machine, and it can give us the hours, the days, and times that they're using it. There are other instances where you may have a night or two where you don't use it, but if you have a patient that consistently every night does not use it, pretty much you get a non-compliant.
No usage, I guess, is the answer to that.
Qualify somebody.
But you can tell when they turn it on and don't
You
use
can
it.
tell when it's just the blower hours, which I have had a patient that, well, I used it, but when you see it ran for 24 hours in a day, you know that's just blower hours compared to 6 to 8 hours a day.
So you could then just get like the air for sleep apnea, like 70%?
No, it's not. No, it's not 70% 4 hours or more. And so,
It's just,
if honestly, we will work with them as much as we possibly can if they're putting in effort. But the patients that are not compliant, they're not using it at all, or they wore it for 45 minutes that month. You know, and when we go in, we have to justify. It's just saying that we're looking at these patients. It's like, all right, this isn't a mask issue. All right, I know you were sick for 2 weeks, but you didn't use it at all. You know, and
So when you go in and someone's not using it at all, or they're trying to, what are the things, what changes do you make
I
in the
look
settings?
at their AVAX rate, I look at their rise time, we look at their other tracks, is it sensitive, is it not sensitive? We look at the mask issues, we look at anything I can tweak. Sometimes they may say the pressure's too high, we can call the doctor, we can always drop that pressure down. It's all fitting the settings to the patient comfort, and that's what we try to
So you do all those settings in one night, or do you come back on Monday and change the rise time,
It's a
Tuesday change the
constantly
sensitivity?
going. I mean, when we first step them up, we make a phone call. You know, we follow up in the home. In the end, our goal is to go out each month, but we can definitely go out more times or as much as needed at the beginning, because every patient is different. There are some that get it just like that.
But when you put it on them when they're awake, and you change the rise time or the sensitivity or the pressure support,
Just tweak it.
does that correlate to what happens at night? Like they say, oh yeah, good. Does that mean it's going to work at night or not necessarily?
Not always. I mean, ideally that would be great. But you know, there's a difference between sitting up in the chair, laying down in bed, pressure weight on the body, positioning, all those things. So it's about a month to actually get everything tweaked to its just right. Sometimes again, people can get it a lot quicker. Sometimes you can't, but it's a process.
And we've asked too, if we can get these in on a patient and make it for their home, if you guys know you're going to discharge this patient and you want to try them on a trilogy, call us. Let's get it in. We have respiratory there on the floors. They can make the changes. They can do our eyes in the hospital. And let's see if this is going to work for the patient. There are some patients it's not going to work for. And Kim will attest. She's gotten some phone calls where somebody wanted to put the bronchodilator medication into the NIV. She's like, no. That's not your nebulizer. That's your NIV. So do not do that. But all of that could be troubleshooted if we knew a day in advance that we at least wanted to try it on the patient. Yes.
Well, first we forgot to thank Dr. Lee for coming. Two things actually. Number one, you kind of mentioned the truth about systolic congestive heart failure. And to be honest with you, I'm a very good advocate of using non-invasive for congestive heart failure, so I don't see it listed here. So if I have somebody with documented recurrent systolic congestive heart failure, in spite of optimizing his cardiac medication, how can I qualify him for non-invasive? That's number one. Number two, when we said so, how can you follow up on the CO2? Do we have any like tribal CO2 that can be used on one of these smart vents? Non-invasive vents?
We have made the decision to purchase anti-CO2 monitor, and Kim can at any point in time. Yes.
we have one.
Fine, we have one.
It's
So if you
an
wanted us,
additional charge, let's put it this way.
we're
And
not
that's
gonna,
something we
we're
don't
not
bill
going
for
to
either.
charge the patient, and there is no billing code for us. And I know she will, if something's going on with the patient and she's in the home and she thinks something is up, she is going to call you and say, hey, you know what, something's not right here, can we run an overnight CFT monitor on the patient? And I'm clinical, I'm the owner of the company, but I'm clinical, so I get the clinical part, and I'm probably 60% clinical and 40% business person, so the 60% is what we want to. You know, but it's like you want to help the patient, and I also know you guys are getting your hands smacked for a readmit. We're trying to help keep these patients out, and I think we've been successful. Our criteria front it's not easy in order for you to order an NIV through us. We roundtable and we decide, you know what, this patient, you know, we have a patient that's been discharged for 2 days, now they want the NIV out there, and her and I are like, really? 2 days later, I'm thinking the person's kind of doing okay. And you hate to say we have to wait for another admit, and the person's going to get intubated, and they're going to be on a vent for 5 days, and they're COPD, so it's going to take longer to get them off the ventilator. That's the way of the world.
This is my question. You still only randomized controlled studies proving that those that can prevent admission and improve survival?
Yes.
Now, you mentioned about heart failure. The study that Bradley did studied before for CPAP and there's increased mortality. Now, the study is pending. That's not for the central CPAP, but for CSF and COPD. Is there any randomized controlled study that's shown that really beneficial on maximal therapy versus no?
So for COPD and heart failure?
Yes.
No.
So this is the patient we are talking about. COPD, we are advocating some modality now, very complicated, very expensive, and there's no randomized controlled study showing that they prevent admission and they improve survival.
We have for COPD and respiratory failure, but not heart failure.
We mentioned COPD and heart failure.
Not
combined.
Okay.
Yeah. And COPD that are stable on maximal therapy.
Yes. So if you look at your question is
I'm not talking about patient admitted to the hospital
Yeah.
with mechanical ventilation,
I know.
operating intubation versus non-invasive.
Okay.
We all know that. I'm talking about outpatient that you're trying to keep them out of the hospital. Controlled randomized study, maximal therapy without the device and maximal therapy with the device. Is there any study showing for 1 year that improves survival
Yes.
or reduce admission?
So if you look at the paper I just described earlier, the Conline paper, okay, showed that there was survival advantage compared to maximized medical therapy by adding non-invasive ventilation to hypercapnic COPD.
You mentioned that you don't know the entry criteria, the entry criteria. What's the entry criteria for this patient?
No, the one that I mentioned was for the survey check. That's different. So can I have my slide?
Yes,
Yeah.
I'll go over this real quick just so we can get through this. Diagnosis-wise, COPD with chronic respiratory failure, we need a PCO2 level. I'll go through that in a second. Neuromuscular disease, so ALS, MS, muscular dystrophy, myasthenia gravis, any restrictive thoracic disorders. OSA, we do not want anywhere on the paperwork. Even if they're OSA, we don't really want to see that. So we don't want to see 47-year-old, patient, history OSA, blah, 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 because they're going to look at it and think BiPAP, CPAP. Even if they are, it can be in their charts, but hopefully it's not real prevalent. So for COPD with chronic respiratory failure, not acute, chronic, we need a H&P sent over. We are not doing 2 or more admits anymore. If they're having encounters with you guys at the office, we can use those. If you're pulling ABPs in the office, if you're able to get them on an outpatient basis, and we're able to prove a PCO2 level of 52 or greater, we can use that. We've made some tweaks to this, just trying to, as they're ogling more of these, seeing what's happening and trying to fluctuate with those. We need a face-to-face documentation. In this packet, there is a sample face-to-face document. What Medicare is looking for, all the other insurances are looking for, is to see that this is life-threatening. Without this, the patient may die. And so when you see the patient, talk to the patient, and chart that, it's really important that they see that. Otherwise, why don't they have a BiPAP? Why don't they have an ST? So it's really important that, and that's part of the same thing. If this is the right patient, then It should be in the charting somewhere.
And if you guys are ever confused or have any questions as to if your patient's going to qualify or when they're going to qualify, just call one of us. Call whoever your rep is, have our telephone number on your phone. We have no issue coming out there and going through the paperwork and kind of seeing what's going to best suit the patient or what they're going to qualify for.
Chest X-rays, PFTs are good. We don't need to have them. But if you think about these patients, you're seeing these patients today. They're coming in to see you for the first time, and you're charting now. That's going to help down the road when they need this stuff. And I think that's where the mindset's going to change. I mean, I know all these ICD-10 changes are coming, and you guys are seeing all these different. You got to prove, all these different things now along the way. If the mindset of healthcare changes and we start documenting a couple years prior, it's going to make everything so much easier down the road. The hard part is right now is that mindset wasn't there 2 years ago necessarily. We started to move into that.
How about the COPD patients with Goulet? Is this advisable for NIV? I mean, possible risk of pneumothorax for these patients.
Yeah. So let me address first the earlier question. we have always been fascinated by randomized controlled trials. We think that is the goal for every treatment decision. But I have to tell you that it takes a lot of time, a lot of money to do a study. And by the time you finish a 6-year study, the technology that you use for that is already 6 years old. Okay, so we have since moved on. But it's still important. We need to prove benefit. At the same time, we need to make sure there's no harm. In your question, sir, earlier, you mentioned, was there any randomized controlled trial? Yes, there is, multi-center. It's a Con9 paper. There's a small number of subjects, I know 195 subjects. Half were on NIPVV and half were controls. They were severe COPD, gold stage 4, and they had hypercapnia. The mean PCO2 was 52. And this shows a difference at 1 year of mortality between NIPVV group. There are other studies looking at readmission rates. There are other studies looking at quality of life. So there are. Are there a lot? No, there are not. But also realizing that this paper is probably outdated now. The technology has since moved on.
So another thing, this study, they actually calculated in the hospital the pressure ensured dropping the CO2, they have targeted CO2.
Yes.
So this is also different than what we do.
We make sure that the CO2 goes to drop.
What about the restrictive lung disease? That's not due to PPD purpose failures, but somebody has one lung with just very people say this is the hyperventilation, and that doesn't be restricted. They're FEV 125%. And they have COPD retention. Does it fall in any one of those criteria for non-invasive?
Yes, so you can also have hyperventilation from restricted lung diseases.
But does they insist here that thoracic hyperscoliosis, you have to have the chest filled for it, or neuromuscular disease?
Yes.
It doesn't matter if they have pulmonary disease with restricted disease. Let's say pulmonary fibrosis or single one. They will not approve that.
Yes, because there's no study.
But the net effect is the same. I mean, they are dealing with physiology the same as restricted disease.
Yeah.
What's the difference between hyperscoliosis, thoracoplasty, and somebody is FEV1 is 25%? I mean, they both have CO2 retention and lung failure, and they need some assistance. And both they will not respond to any medications, but they are worse than COPD. They simply not able to accept mechanical ventilation.
So the reality is both good and bad. The reality today is that we live in a medical world that is business as well. Right? So the payers, you may argue with me, are not the enemy, right? They just have a different mindset. We have a face-to-face engagement with the patient. They have objective view of healthcare. We treat one patient at a time. They have to look at populations. They need to see cost-benefit analysis. We hopefully do not have to do that. So the prioritization is different. You will do everything you can to help your patient. I have no doubt about that. Okay? And your patient trusts you to do the best. You will not defraud them of good treatment, and you will not give them treatment that is not necessary. But I have to tell you too that in the real world, there are a lot of people who may think differently from you. And, and I think it is the job of the insurance companies to make sure that fraud is kept on minimal. So therefore, evidence is important, okay, and we need to live by that. But I also have to tell everybody here that at the end of the day, evidence only guides us. It's a roadmap to the best care. It is not the only way. And I have patients who, like you said, do not satisfy the criteria for CMS, and I was able to convince them that it's beneficial. And then,
I'm going to interrupt real quick.
Yeah.
I'm sorry. We're kind of going over on time. I don't want to keep you guys all here. We're going to break up into some small groups. Feel free. One of us will be there. There'll be respironics people around. Dr. Lee will be around to answer some questions. I just don't want to keep you guys all here. We are going to have a hands-on portion now. So if you, we're going to got 6 trilogies with test lungs. You can look at settings. You can ask questions. I just don't want to go way over on the time when we started a little bit late. So we'll have some time afterwards for questions. And you guys all have these packets. Ask us individually if you can. We'll help you do whatever we can. We really appreciate you guys all coming. And we'll break off, take a quick break, go to the bathroom if you need to, and then we'll get going on the hands-on. Thank you.
Yeah.